So I'm a radiation oncologist, and I treat primarily breast and lung cancer. They're also the two most common cancers to metastasize, hence my appointment in neurosurgery. So I do a lot of radiosurgery. But I'm going to talk to you about SGRT for left-sided breast cancer and what little evidence there is. So let's get started once I figure this out. Okay. So Vision RT pays my mortgage, and Accuray pays alimony for my first ex-wife. Why do we care about radiation-associated heart disease? Because it's real, right? So patients actually die from this. It was once thought that clinically relevant cardiac disease took decades, 15 to 20 years to develop. So if you look at the old meta-analyses, we thought that this took a long time. However, in re-looking at the data, it seems that this radiation-induced heart disease may become manifest a lot sooner. These lights are so bright, Jesus. So I'm going to try not to talk about too much data because it's boring, but there was a large review of more than 40,000 women that were treated with radiation or without, so more than 23,000 women. And radiation was shown to improve local control, breast cancer-specific mortality, and actually overall survival versus those that didn't get it. But there's a risk, right? You know, not everything is free. Women that were irradiated were 27% more likely to die from heart disease, okay? So this isn't like, oh, I have chest pain. I mean, this is clinically significant disease which actually can take patients' lives. So this is, as I think everybody in here knows, an illustrative CT with standard tangential beams. Is there a pointer on this? Anyway, maybe? Okay, that's wrong. Why is there a blank button? Anyway, so you can see these tangential beams clipping a large portion of the left ventricle. This is obviously a very poor example, which is why I chose it. There's a lot of heart in the field. Okay. Multiple different ways to limit heart dose. One is a straightforward heart block. This has been used for decades, where you essentially just block the heart with, in the old days, Serabin, now with MLCs. DIBH, I think everybody in this room is familiar. Vision RT, in my opinion, is the best. I've worked with RPM, and people have asked me to use ABC, and I don't think it's comfortable for patients, so I won't use that. And we'll talk a little about intensity modulated radiation therapy, and rather than sparing, well, you spare high dose, but you get low dose, so we'll talk about that too. And prone, there are a lot of advocates, especially in New York, who think that you can limit heart disease or heart dose if you treat a woman prone. So this is a DRR of a left-sided breast cancer patient with a heart block. It's not just a clever name, it blocks the heart. Okay. Here we have an image to show that we may miss the lower inner quadrant with a heart block, which isn't a big deal if you're postmenopausal and you have an upper outer quadrant tumor, but if you're young and have a midline tumor, you can't skimp, and necessarily you may have to treat some heart. These are just a series of images showing that as you get older, your heart gets bigger, it gets closer to the chest wall. I think the take-home point from this slide is that everybody's heart position is different in relevance to the chest wall, okay? So with deep inspiration, you can see here on this coronal MR, the heart goes inferiorly and posteriorly. So we're basically taking advantage of a normal natural act of breathing to try to help improve the therapeutic ratio and get the heart away from the beam. So DIBH allows us to decrease the heart dose. It also reduces tumor bed motion, right? So if you're treating somebody free breathing, things move, right? The chest moves. And it can also decrease the absolute amount of lung that gets radiation. Okay. So IMRT is really hot, right? Because it's really expensive. People get paid a lot, so we like to use it. When you spare the heart from high dose, which is very possible with IMRT, you get a resultant low dose bath. And I happen to believe that this low dose is important, but we've never actually proven it yet. But you can imagine that if you give 10 gray to your whole heart, it's probably not a good thing. People do it, right? So I think this is a very important study that I won't spend too much time on it, but this showed in the New England Journal that even a little bit of radiation causes a lot of heart disease. So for every 1 gray that the heart gets, the average dose of the heart of 1 gray, 7.4% more likely to die or to have a severe cardiac event with as little as 1 gray. Okay, so that's shocking. But, so now this is not as good of a study, but this came out of Michigan, where they essentially looked at patients with IMRT and showed that there were no increased defects. So one of the gold standards, and I'm going to talk about this as it relates to my research, is SPECT scans, so single photon emission CTs, which is kind of an old study, but we still use it. So Michigan looked at these people with IMRT and found essentially no cardiac imaging defects when hearts were exposed to mean doses of almost 3 gray. Again, I don't necessarily believe that. So let's talk prone, right? So prone, you can essentially decrease the dose to the heart, but you necessarily change your target, right? So if you look at this tangent beam, you are no longer treating the chest wall. And people that treat prone say that, well, the breast tissue falls anteriorly, so you don't need to treat it. But it's, I don't know, you're fundamentally changing the target. So we have decades of post-lumpectomy radiation where the chest wall is target. Now you flip them over and you don't treat the chest wall. Yeah, you spare the heart, but you're not treating the chest wall. So I don't know. I'm not a believer in prone, but there are certainly people that are. Okay. So this is what I alluded to before. How do we image cardiac defects? So my chairman and mentor, Larry Marks, did much of this seminal work while he was at Duke. And he looked at women with left-sided breast cancer and irradiated them. No breath hold maneuvers, nothing fancy in the early 2000s. And he found that 50% of patients at 6 months developed a cardiac perfusion defect. Now, I'll say that this is objective evidence of obviously some radiation-induced cardiac injury because there is no perfusion in the anterior portion of the left ventricle. But nobody really knows what these mean. So he followed these patients out for years. And it was difficult to correlate who ended up developing heart disease or had left ventricular dysfunction. But this is relatively soon after radiation, objective evidence of radiation-induced heart injury. So this has become the gold standard of how we image early radiation damage. So what did we do? So at UNC Vision RT, we basically took women with left-sided breast cancer, not just early stage, we even treated patients with nodes, and we got so before we designed the radiation, we made sure that with a deep inspiration, we were actually able to completely exclude the heart from the tangent. And in these women, we then got a pre-radiation SPECT scan, and provided they had no imaging defect, we then enrolled them on the trial, gave them their standard radiation, and then 6 months out, we repeated the SPECT scan. Okay, so whatever. So we ended up getting 20 patients. 25 were enrolled, but for various boring reasons, we had 20 follow-up scans. Busy slide. Yeah, most were postmenopausal, most got chemotherapy, most actually had risk factors for heart disease, smokers, diabetic, whatever. So essentially, all women that had no cardiac perfusion defect before radiation, 6 months post, didn't have a cardiac perfusion defect. So I guess this is a fundamental proof of principle that Vision RT actually works, which I think you guys are happy about. It would have been pretty embarrassing if it didn't. Right. So, and here, the only reason I put this slide is we were able to achieve median heart doses of 94 centigray. And mind you, these patients also, I treated nodes in about half of them. So these are really low doses, and all of these are from scatter. You can't get lower doses to the heart because this is not from the primary beam. So this is incredibly low. But if we go back to that New England Journal paper, no dose is too low. So we want to get as low as possible. So please move. Okay. So this is a study that I often talk about that was published now, I guess, 2 years ago. Similar study to ours, and what they did was they did DIBH. They got a pre and post SPECT scan. But the way they did the DIBH was with ABC, so varians, where patients are, confined to breathe, and they had SPECT scans before and after. Okay. Patients were more likely to have cardiac perfusion defects in the breath hold group. And authors, we postulate that when you have a new technology, you sometimes overestimate how good it is. So if you have this great technology, maybe they drew their heart blocks too tight, so then in a practical day or day-to-day setup of patients, if you're off by a few millimeters, maybe, a portion of that left ventricle, because your heart block was so tight, was getting full dose and you just didn't know it. But again, I think I need to repeat that despite this early evidence of radiation-induced heart damage based on these SPECT scans, we don't necessarily know what that means, which is a little frustrating. So one of our interests at UNC, and I've talked to the folks at Vision RT, is we have a PET MRI unit. So we're about to start doing cardiac PET MR to see if, SPECT is an old technology. So maybe that with newer novel imaging, newer tracers, maybe we can get more insight into early radiation-induced heart disease so that maybe we could stratify and predict those that may go on to develop heart disease for early intervention, like oncocardiology, which is going on a tangent, but there's a new field in medicine that's called oncocardiology, where it's cardiologists that only deal with cancer-associated toxicity in women, and in men, obviously, but primarily women with breast cancer. So it's really fascinating. So in this single institution phase 2 trial, we were able to put on 20 patients and demonstrate that Vision-RT can prevent cardiac perfusion defects. We are able to decrease the mean dose to the lung to very low values. And we still don't know what that means, but Vision-RT works.